Welcome to the GeriPal podcast. This is Eric Wadera.
This is Alex Smith.
And Alex, we got a live in-person guest with us.
Live guest, Nate Chin, who is our visiting professor for Grand Rounds and has got a full day and is joining us for the podcast to start things off. Nate's a returning guest. He is associate professor at the University of Wisconsin and medical director of their Alzheimer's Disease Research Center. Nate, welcome back to the GeriPal podcast.
Oh, thanks for having me. Great to be back.
So we're going to be talking about making the diagnosis of Alzheimer's disease in a primary care setting. Not specialty care, but maybe we could talk a little bit about that. But before we do, we always start off with a song request. Nate, what is your song request for Alex?
Jungle Land, Bruce Springsteen.
Why did you pick this song?
This is in honor of my father-in-law, Steve Hoppy, who passed away last fall. He was a diehard Bruce Springsteen fan, and he went to, I think, over 30 concerts. And my wife went to over, I want to say 20 concerts.
Have you been to a concert?
I went to one in Milwaukee, Wisconsin, and I'm so glad I did. I loved it. And this was his favorite song, and so I wanted to do it.
And Bruce Springsteen did a stage dive. We were talking about this before.
Very healthy man.
Very healthy man. I wonder how old he is now. And he's stage diving. And he's incredible. All right, here's a little bit. The Rangers had a homecoming in Harlem late last night. And the Magic Rat drove his sleek machine over the Jersey state line. Barefoot girl sitting on the hood of a Dodge, drinking warm beer in the soft summer rain. Rat pulls into town, rolls up his pants. Together they take a stab at romance, disappear down Flamingo Lane. We'll have more later because it's like a story.
I was going to say, wait, I was waiting for. Is this the end?
No, there's no chorus. It just goes on and on and on, verse after verse after verse. It's a beautiful story, and it just reminds me how much of a storyteller he is. Okay, non sequitur. I just saw that movie, A Complete Unknown, about Bob Dylan. Incredible movie. I loved it. Timothée Chalamet did a good job. A lot of the co-stars did a great job. And I would say that one thing I wish it did better was show how Bob Dylan told stories with his songs in much the same way that Bruce Springsteen does. And someday there'll be a great documentary about Bruce Springsteen.
I think this is just a plug for future guests that Alex wants more Bob Dylan songs. Don't let him fool you, future guests. All right, let's jump into the topic. Things are like changing real fast, Nate, in the Alzheimer's world. So we now have blood tests that can reasonably approximate the degree of amyloid buildup in the brain. You got 2 new FDA-approved meds that you can give to shrink that amyloid all away. How much has this changed? How much should it change how we think about making a diagnosis of Alzheimer's disease in primary care? What do you think?
I don't think it changes anything about what we should be doing in primary care. And that's because the syndrome of mild cognitive impairment and dementia doesn't change, right? So we need to know if a person's having symptoms. We need to know if people are forgetful, if they're losing their attention, if they're struggling to solve problems like cook or clean or do any of those things. So knowing if it's amyloid or if it's tau or if it's Lewy body disease or vascular disease, that doesn't really matter because we need to know what people are experiencing. And so I don't think the biology is incredibly important, so don't get me wrong.
Yeah.
But what people are experiencing, which is fundamental and what we really care about, that hasn't changed. And so in primary care, which they're perfectly situated to address, that hasn't changed.
That's fascinating. So it sounds like what you're saying is like making a diagnosis of cognitive impairment is kind of paramount first over making the diagnosis of Alzheimer's disease. Did I get that right?
Absolutely. Absolutely. Fundamentally, we need to be better, all of us, at addressing symptoms and getting to the diagnosis of MCI and dementia.
All right, I'm going to start off at the beginning then. So let's just say you have a healthy 55-year-old or 65-year-old in your clinic. Who do you think we should be screening, and how should we be screening them for these symptoms?
Ooh. Well, so I guess it depends on what you say screening, because if you're the United States Preventive Task Force, they're going to tell me, well, don't screen any asymptomatic person. And what they're really saying, which is fair, is don't be giving a cognitive screening tool, a MoCA, a mini mental, to someone who's healthy. And that's fine if that's what the evidence is bearing for now. But really,
because we got no good randomized control trials that screening influences kind of further treatment, actually probably more importantly, patient outcomes.
Right. And it can cause harm because if you're springing this test on someone, it actually can create a lot of anxiety. It can create mood changes. Yeah. So, but the key part of that is asymptomatic person.
Yeah.
So who should we be screening as far as, are we worried about our thinking? Everyone. So whether it's 50, 52, 55, 65, we should ask every person who comes into clinic at least once a year, how do you feel like your thinking is? Do you think your thinking has changed compared to last year, 5 years ago, 10 years ago? It's a simple question. It normalizes the fact that there are other factors besides Alzheimer's disease that can affect our thinking, like depression, like sleep apnea, like your medication side effects, like your thyroid. So every person should be asked, what's your thinking like?
But and you're not categorizing that as screening for Alzheimer's disease or mild cognitive impairment. You're calling that screening for thinking issues, which is you're saying is different.
Well, yeah, I mean, I guess I'm kind of walking that line because if that person says, well, you know what, doc, I do feel like my thinking is different. Ooh, well, because now I want to explore that. Because now I'm going to characterize what is that thinking change, and that gives me one of the criteria potentially for MCI. That's that subjective complaint. And then that would actually lead me to using a screening tool like a mini mental or a MoCA to look for an objective impairment.
Okay, I got a question then.
Yeah.
There's this also idea is as we age, our body changes. Organs change. Our way we think changes. Sometimes for the negative, sometimes for the positive. There are some things we do better with age as we think. There are some things that we do worse. How important is it that, compared to 10 years ago, I think differently than I did 10 years ago.
Yeah, and I think that's true. Now, we're all geriatricians here, so I do want to be careful that just getting older doesn't mean everything's declining, right? So you did say some things get better, wisdom gets better, emotional maturity can get better. And
I'm not sure that got better for me, but
and there are some.
Ask your wife.
Yeah, right. I didn't want to say it. You know them better than I do. And there are some lifespan studies, right, that at the age of 25 we reach our peak cognitive performance. There's gradual changes, so I recognize that, but I do think that we are really entering this age of, are we really at our optimal? If we truly address all those health factors, brain health, if we truly are addressing those, perhaps we could be better than what we're doing. And perhaps that means even now, maybe I'm not at my best. Maybe you're not at your best. I do think our culture, we have undervalued sleep for so long. Only until the 1960s did exercise really become something. And so are we truly addressing those lifestyle factors that could be leading to cognitive reserve? And with the Lancet Commission coming out with those 14 modifiable risk factors that could prevent dementia, could those actually lead to improvements in cognition? Right? We have those studies that show cognitive ability can improve when we address some of these things. Mm-hmm. And so asking about that, I mean, perhaps people could actually feel better. And then we're just talking about well-being.
Yeah.
But if we catch someone who says, well, actually, I do feel like my thinking is worse, well, then I think exploring that is worthwhile and could lead to people feeling better. Mm-hmm. It could also catch the very earliest change of MCI, and then we do go down that path.
Yeah, so maybe we wouldn't call that a screening question. Maybe we'd call that more of an assessment of people's thinking, and that a yes/no response isn't sufficient for the clinician. You have to probe beyond that to see whether this is a concerning, maladaptive change in the way somebody's thinking or not. And also a plug for our listeners to check out our podcast with Christine Yaffe on prevention of dementia through changes in non-pharmacological behavior and lifestyle factors.
I'll put that in the show notes too. And I love this, what you're saying, Nate, because my sleep has not been good in the last couple of weeks. And I actually do think that's affecting my thinking. and I should probably do something about my sleep. Like that question opens the door for so many different avenues that you could potentially address, from mood to sleep to exercise. So I love that question. And as far as the next step, when would you do the like a objective cognitive screener?
Well, you know me, and so we're talking about primary care, and so I'm a little bit biased here. So I'm in a specialty clinic, so I'm in this interdisciplinary memory assessment clinic. So I get all the referrals from my great colleagues in primary care, and I'm seeing people coming in with mini mentals of 10 out of 30 who we end up doing thorough testing, and they're perfectly healthy and they're scoring well. And when I asked the patient, well, what happened? The test was sprung on them. It was administered by a well-meaning person who doesn't know what they're doing when they administer the test. It was rushed. They said to them, you have dementia, and they never really conducted a functional history. And so I'm seeing case after case of these really bad situations. And I know there's plenty of good situations out there too, but what I'm seeing are scores that are meaningless. And so I really worry about cognitive screening not being done properly. And I do say this, knowing that I don't administer these cognitive screening tests in the right way. And I work with a lot of neuropsychologists, and they will all tell you, I don't do it well. I'm holding on to the MOCA instructions, and I'm reading it verbatim. I'm like a machine done, and I'm not doing it well. If you aren't doing this regularly, if you aren't confident in what you're doing, if you don't show compassion and yet stick to the rules, these instruments aren't that helpful. And so I do worry about cognitive screening in primary care. And I know people don't agree with me in this. I know lots of people don't agree with me in this. And so it's hard for me to imagine the beauty and complexity of the human brain broken down into a number that is done in a 10-minute test. And I know we want that, but these tests were never designed to diagnose.
10-minute test, 2-minute test. You got your mini cog right there.
Mini cog. And a shout out to our podcast with Sue Borson, creator of the Mini Cog, and Anna Chodos about assessment and screening, similar to this podcast, though.
I got to keep on writing down all the podcasts Alex is plugging right now, so I don't forget to put it in the show notes. You guys
have done some great interviews, and I know Dr. Borson, and I mean, I think that's incredible work. I just think when it's hard. Yeah. It's hard to break down what the brain can do into something so simple. You know, it's meant to filter. It's meant to screen who really is impaired or could be impaired and who's not. But it's so much more difficult than that. Whereas if you look at function, if someone comes in and tells me, I am struggling with remembering things that just happened to me, well, there's my complaint. And then the family tells me they can't keep an appointment. They can't manage their finances. What is that screening test going to do for me? I already know that the complaint is severe enough that it's starting to impact their function. That is enough for me that I would want them to come to my clinic where I have a neuropsychologist that's going to conduct a 50-minute thorough cognitive assessment. And now I'm going to get a real sense of what the brain is able to do. I just don't know what the point of that screen is going to do. It might actually scare the person. It might make them so frustrated they're not willing to come into me.
That sounds so hard, Nate. Like, it's hard to do it well, even for somebody like you who's pretty familiar with the instruments. It might cause distress for the patient, maybe their family. There's got to be an easier way. And I have to ask them about all these other things like seatbelt use, and I got to manage their blood pressure and their diabetes meds. I'm just going to send them to the lab and get the blood test.
Ooh.
You mean a TSH, Alex?
Well, I appreciate that. Thank you. Because I would rather you look for reversible causes, right? I'd rather you do something like that. No, I don't want you to get the blood test. And I don't know if the others in the specialty world would disagree with me, but I'm not in favor of these blood tests being in primary care.
And we're saying the blood tests. We're being facetious with the TSH, the RPRs. You're talking about amyloid biomarkers.
I am.
Your p-taus, your amyloid ratios. Like, those are the things we're talking about right now.
That's right. That's right. And they are incredible tools. And for my grand rounds, I'm going to be talking about what they can do. And I think it's amazing at a scientific level, even at a clinical level.
For our listeners, could we give a preview? I'd love to hear more about that. I'm sure our listeners.
What do they do?
Yeah.
So what can they do? So they can reliably detect the presence of amyloid up to 10, 20 years before a person develops symptoms. In certain groups, and this is all cohort-based, meaning these are just in certain...
And when you say certain groups, you mean very white, wealthy folks?
Well, I mean, in the RAP population, Wisconsin Registry for Alzheimer's Prevention, 22% of our population are African Americans.
Hey!
And so, or I should
Things
say
are changing.
underrepresented groups. And
yeah.
so it is changing slowly. Yes, they're predominantly white and urban and well-to-do, but that is slowly changing. And the numbers still are different. So you're right. But that is a reason why we do need more people of color to come in so that we can understand it. And it still could be different. And I think there are reasons for that. We need to understand that. But it doesn't change the fact that when you do have amyloid in the brain, there is this very strong connection between amyloid chronicity, meaning how long you have amyloid in the brain, and the likelihood of developing tau, and that's Alzheimer's disease pathologically, the likelihood of having cognitive decline on testing, and the likelihood of developing dementia. There's a biological timeline that we are really starting to be able to describe. And it all starts with the first identifiable process, which is amyloid. And so when you start seeing this, it's pretty convincing how important it is, at least from a scientific perspective. And then you're going to ask the question of,
is it deterministic? If you have amyloid, will you develop Alzheimer's dementia?
And just to be clear here, are we still talking about the blood test for amyloid, or are we talking about like CSF or imaging studies? What are we talking about?
Well, no, the blood test, I mean, these days the blood test looks just as good as the spinal fluid, and it looks almost as good as these PET scans. The PET scan has really been the gold standard biomarker tests, but it does look really good. Now, frankly, at UCSF, the researchers here are phenomenal when it comes to these PET scans. I would say the researchers in Wisconsin are really good too. And they're showing they're comparable. I mean, there's certain advantages to the blood tests. Obviously, it's a lot easier to collect, more scalable. We can get more people, particularly people in where we've had difficulty in recruiting and engaging in those communities. And that's on our end. It's not on the community's end. PET scans, though, the beauty of a tau PET scan is you can see where the tau protein is geographically in the brain. And I think there's a lot of value to that. But we're getting into the weeds. I just think there's a lot of power in these biomarkers. But to the person, I would say that when a person comes into a primary care clinic, you want to know, well, what exactly is happening to me?
Yeah.
And first thing is, well, let's describe what's happening to you. And that's what primary care is really good at. Let's collect that history. Let's look at those reversible causes. And then let's start talking about the potential brain diseases. And that, of course, if you feel comfortable in primary care, then great. If you want to see a specialist, that's where I would potentially do that handoff to a specialist, and they would be doing the blood test, I would actually do neuropsychological testing first and then do the blood test.
Yeah. I do worry a little bit because I recently had a primary care appointment. Well, not recently, like 6 months, a year ago. I forget when, after not having had one. And even before I saw the person, I just had lab tests done. I didn't know which lab tests, got my lab tests, looked on there. All of a sudden, as a 49-year-old, I see I have a PSA on my on my lab test. Like, there was no shared decision-making about the PSA. Yeah. It just happened. So
this is the reality. Same thing happened to me.
Yeah, right?
Yeah, I got a PSA.
Yeah.
Well,
I also had like these, like my lipids were broken down into every possible category. So I worry that this is going to be, like Alex said, it's the shortcut. Like, you could spend a half an hour with a patient, getting a great history, functional history, doing an exam, doing some basic workup first, and then getting, those amyloid biomarkers, potentially, or just sending them to, specialty clinic, or, press the easy button, get that amyloid blood biomarker, and call it a day.
Yeah, and well, first of all, let me say I feel sorry for the two of you, because that is a horrible experience. I don't want to speak to your healthcare system and what's happened, but that to me seems inappropriate. I recently turned 41, so when I turned 40, I went in to get my checkup. I hadn't been to the doctor in 5 years, and I'm the one who said, please, can I have an A1C? Can I have a lipid panel? I want to be checked for these things. I had to ask for that. There was no labs ahead of time, and that's how I think things should be. And so maybe it's a little bit different in the Midwest. I don't know. But I don't think it's appropriate to order these things in advance. I agree with you. Shared decision-making is critical. I do think there is something different about Alzheimer's than there is about high cholesterol and even a prostate cancer. Cancer, I know, is still a scary word.
Yeah.
But I do think someone has to own the result and the counseling of that result. So for primary care providers, you order that blood test, you own that. And I think that's a common part of our culture. Mm-hmm. You should be scared. You order that amyloid test and you don't have shared decision-making, you should be fearful of having that conversation when your patient comes in. I think that fear is enough that you're not going to order it.
Yeah. Fearful of it coming back positive and you hadn't had the conversation, and then what?
And what does it mean?
Right.
Yeah, and then how are you going to explain this to the patient?
How does it mean to, let's say, an asymptomatic 50-year-old?
Oh my gosh, right? And because that's even being debated in the field of experts.
We don't know what it means yet, right?
Well, but didn't you just say a little while ago that there's a clear correlation between these biomarker tests and development of Alzheimer's disease?
I don't like how close you listen to me, Alan. So there's a debate in the field as to the definition of Alzheimer's disease, right? So the new criteria came out. Amyloid alone is enough of a definition of Alzheimer's. So in someone who's cognitively healthy, having the presence of amyloid would be enough for the definition of Alzheimer's
disease. Is that a done deal?
That is per the Alzheimer's Association.
That's only per one set of criteria, right?
Per the Alzheimer's Association. That is a done deal to the Alzheimer's Association.
Done deal to the Alzheimer's Association. There is a different work group.
There's an international work group. And then there's clinicians in general who are facing patients who are asking these questions too. And so I think there's just a discussion in the whole field about, well, what are we talking about? And certainly the criteria said we shouldn't be testing people who are cognitively healthy.
Yeah. That is on box 4, page 14. Nowhere else. One sentence. You shouldn't do this. You shouldn't test asymptomatic people. No suggestion of what you should do with subjective cognitive complaints. Like, is that okay to test people? Like, if somebody comes in, they watch an advertisement during the Super Bowl, they say, hey, if you forgot your keys, you should talk to your doctor about, checking your amyloid levels in your brain. Eli Lilly. They're not asymptomatic anymore. They have subjective cognitive complaints. Hey, let's press that easy button and let's get those Alzheimer's biomarkers done.
I think they were saying that if you weren't impaired, though, because they're breaking into asymptomatic MCI and dementia. So I think they were grouping everyone into that one.
I just think it should, if they don't want it done, that should be on page 1. Don't do it.
Wait, they meaning the Alzheimer's Association?
Yeah, in the work group.
In the work group. And these are the proposed guidelines.
I'll get off my my bandwagon.
We want to hear this. This is
one of the proposed guidelines on how to diagnose Alzheimer's disease.
Okay, and it's proposed.
Yeah.
Okay.
Or define Alzheimer's disease.
Okay, not accepted dogma throughout the field yet.
Well,
maybe. Although Nate sort of talked about it just a moment ago, like it was maybe.
Well, so what I'm saying to you is that when you start looking more and more at these cohort studies, meaning individuals who have volunteered for decades, and you start looking at the science of what happens when people are followed and they have amyloid in their brains, and you see that many of them, most of them are developing tau. And if you follow them long enough, are they developing symptoms? And we need to follow them longer. And I can speak to the WRAP study, the Wisconsin Registry for Alzheimer's Prevention study, and that's been around for 24 years. And we are seeing people with amyloid, and nearly all of them that develop amyloid that live long enough, that have amyloid for more than 22 years, are developing tau.
So we just got to follow them for 100, 200 years. And then all of them will develop Alzheimer's disease.
And I thought you were going to end that with, and many of them are developed tau. I thought you were going to end with many of them develop Alzheimer's disease. Developing tau is not a disease.
Well, no. So if you have amyloid and you have tau, biologically, so prior to the new criteria that were proposed in 2018, the criteria were the presence of amyloid and tau was the definition of Alzheimer's disease. And that is the neuropathic definition of Alzheimer's disease. And so now you're getting into the nuance of, are you accepting of an asymptomatic phase of Alzheimer's disease?
Or subjective cognitive complaints without any objective. Like asymptomatic assumes that there's Where does the subjective cognitive complaint I forgot my keys. I'm forgetting some groceries. Commercial says this is more than normal aging.
Yeah.
But when Nate sends me to the neuropsychologist, they do this testing. They find nothing.
Yeah.
But somebody checked an amyloid test on me and it's positive. Do I have Alzheimer's disease?
Yeah.
I think that is the big controversy right now. What should we label those people? Not just asymptomatic, but subjective cognitive complaints. If somebody does this test, and per the Alzheimer's disease work group, it is you have Alzheimer's disease. Oops, you shouldn't have done it, but you got it.
Yeah.
And why does this matter? Whether you what we call it, is this just semantics? Whether we call the person, we say the person has Alzheimer's disease or doesn't. Like for the perspective of advancement of research and development of interventions, maybe we do want to call it Alzheimer's disease. Whereas maybe from the perspective of a patient who has got some subjective mild memory complaints and a positive amyloid blood test, they don't want to be called, labeled as having Alzheimer's disease. They're still working. Like, what's their employer going to do?
Right.
Yeah, they're an airline pilot.
Yeah.
Can they fly anymore? Because they have Alzheimer's disease.
Right. So it matters a lot to the person, to their family, to the community, right? So that's a powerful term.
Yeah.
And so if we're going to be using that term in a new way, there's a lot that has to go into the education and reframing of that.
Yeah. And diagnosing a disease drives treatment. So there will be an inherent push to start, these amyloid antibodies in people who don't fit the categories that were included in the studies, MCI and mild dementia. You have somebody with subjective cognitive complaints, no objective issues, but they got a positive amyloid. That's pretty scary. What about these amyloid drugs?
Like lecanemab, donanemab, those drugs.
Yeah.
Those drugs. But now there are already those studies, though. So Trailblazer, ALZ 3, and then the AHEAD study. These are good studies that will likely result. AHEAD will probably result in the next couple of years. Trailblazer, ALZ 3 could potentially result this year or next year. And those were people who do not have MCI, who have amyloid in their brain, were given these monoclonal therapies, and they are looking at those similar outcomes.
Yeah.
So that would potentially tell us what is the meaning of these interventions in those individuals.
So this is what Eric was talking about. This is the patient Eric's talking about.
Exactly.
Who has some subjective memory complaints, but doesn't even have doesn't even meet the criteria for MCI.
Correct.
And we're starting them really early.
Right.
And my recollection from the early drug tests for anti-dementia medications was you got to start earlier probably because those studies were negative. So maybe there is a scientific rationale that if we're going to intervene, it's better to intervene early than later, right? Could be.
Yes.
Could be.
That does make sense. And in donanemab's phase 3 study, Trailblazer ALZ 2, they split people into those who had low, medium tau and those that had high tau. And those that had low, medium tau did respond better to donanemab than those with high tau, suggesting that those who were earlier in the disease do respond better to therapy than those later in the disease.
So what's the harm here? I think we should be, shouldn't we, don't we want to know early? I mean, I would want, does the public, if you ask the public, if you ask older adults, don't you want to know early on the chance that you might be able to intervene early? You think about the number of people who sign up for clinical trials, et cetera, on the basis of, they think it might help them, though, it's not, these trials are designed to help future patients. Most of the public wants to have access to treatments and interventions that might help them forestall a devastating illness.
But we're waiting. But I think we've kind of gone off on a different path here, but we went from primary care to this.
Welcome to the GeriPal podcast. It's not as formulated as Dementia Matters, your own podcast.
But
Dear listeners, I'm trying to be provocative. Let's see if I can get a rise out of it.
And I think, though, that, this is the point of scientific investigation and clinical trials. And, Eric is bringing up some really interesting and important questions, which are being addressed with these clinical trials. And so for our listeners, we should come back to this episode because when these trials result, Eric might be sitting here and saying, see, I told you. Like these trials are going to tell you, don't do this. Or
Hey, it worked. Let's change this definition. Of
Or
Alzheimer's
Eric is
disease.
going to have me fly out so I can sit here and be like, well, now what are we going to do, Eric? Because these trials resulted and there's benefit. And I know what he's going to say. Well, it's a clinically meaningful.
Yeah,
I don't know.
we all know if
right,
it's
so-
beneficial. It's going to be some.
Well, and we can have that
small.
conversation. But there is rationale. Earlier is better, but we do need to prove that in a trial, in a structured, scientifically sound trial. Yeah, and so that is for a different population than the person coming into clinic that has a diagnosis of MCI or dementia.
Well, I got to ask another question about trials because there is this discussion online about maybe not even online, FDA. What about just forgetting these, patient outcomes and just look at these surrogates like amyloid as our result for the trial? Like, should we just say for these, new studies, all that really matters is, does it reduce amyloid? That is a great surrogate marker because, as you said, Nate, if you follow people long enough and if they live long enough, they're going to develop Alzheimer's disease, maybe, mostly. Well, let's just use that as our surrogate.
Well, no, I don't. I mean, ultimately, we're in this to help people. So that's a dangerous path to walk down. I do think, if earlier is better and you want to talk about prevention,
Yeah.
and it takes 30 years, 20 years of developing amyloid and tau and 10 years of developing symptoms and then dementia, we can't wait that long for a prevention study to then see if it works or not. So you do need a surrogate in a prevention study. And I mean prevention of developing the amyloid that you would have to have already established leads to the development of dementia. So you already have to do steps before you get to that. And that's what these longitudinal studies are so important for. So, I mean, what the interesting thing to me is that I hear a lot about, well, these clinical trials are they going to put longitudinal studies out of business? Like, do we need longitudinal studies? I think it's the complete opposite. I think these clinical trials are emphasizing the importance and gratefulness that we have for participants who've been in studies for 30 years because we need them to continue to be in studies because ultimately we need to know the questions that we're getting at. Does amyloid always lead to dementia? And we need people to be in the study for 40 years, 50 years to know that. Because if we do know, if we can show in multiple different cohorts, meaning Wisconsin and ADNI and Baltimore and Mayo and down in Texas, if we can show that if you develop elevated amyloid and that will lead to dementia if you live long enough, well, then that's your conclusion. Then removing amyloid or preventing the buildup of amyloid means you prevent that type of dementia. We still haven't talked about vascular and Lewy body. Yeah. They're equally important. But I mean, at least that string of dementia could be prevented.
So can I ask you then, going back to the biomarkers, I've heard that the most common type of dementia is mixed. There's a lot of going on in the brain from vascular issues. And when we think about prevention, like there's more to it, even like depressive symptoms, sleep and everything else. When you get a positive biomarker, how do you interpret it knowing that there's probably a lot of other things going on in the brain?
Absolutely. It's just one piece of data. And that's why a biomarker can't give you everything you need. You need a clinician to put everything together. Yeah. And I mean, I feel like you're just giving my grand rounds for me. I mean, honestly, I was going to practice before 4 o'clock today, and I don't feel like I need to. I feel like this is done.
Warm up.
I talk about.
Can we just show this video during the grand rounds and you're done?
I could just sit back and
just bring my guitar.
I could have some fish tacos with you guys and just sit around. No, I agree with you, and I think what is super fascinating to me. I don't want to go too much in the weeds, but what I find really interesting is the timing aspect, and this is why I think the biological process and timing of these biomarkers is so important. Let's say someone comes in and they have dementia. We've diagnosed them. We've done this proper workup. They have dementia, mild stage dementia, and we get a PET scan and it's amyloid elevated. Well, traditionally we would say, okay, well, you have dementia and it's due to Alzheimer's disease. But if we knew that they had just become elevated in amyloid, that 2 years ago they were not elevated and they just became elevated, I would say to you, no, that's not Alzheimer's disease dementia. Something else has been going on for years that caused that dementia, and it just became, yes, it's Alzheimer's, this process is probably there and it's building.
Because every decade you get older, the chances of you having amyloid in your brain increases.
Is increasing. But I would say something else is there. So I actually think there's a lot more nuance to just the biomarkers. So there's other things that are happening that are probably contributing, but even just the nuance to the biomarker and the timing, which is why I worry about primary care having to go through this process and explain it. Because when I think about it, and I think about these things every single day, it takes me 30, 45 minutes to talk to my research participants about these biomarkers. And a primary care provider has 18 minutes. And Alex said they got to talk about other health conditions, equally important, high blood pressure and cholesterol. How can I expect a primary care provider to do that?
So I do want to acknowledge something about Alzheimer's Association. They actually published a really good article in like December on what's the role, like how should we diagnose Alzheimer's disease in primary care. Beautiful flowcharts. And it kind of mimics exactly what you're saying. The role of the biomarker comes very late in that diagnostic pathway, generally at the specialist.
Right.
And in primary care, it's what you're saying. You do the history, you do a physical exam, you're doing non-specific, blood tests and potentially imaging. And only after that do we even consider the role of biomarkers. Does that sound right?
It does.
And when you say non-specific blood tests, you're talking about like the TSH, the RPR, that sort of stuff? Okay.
Yeah, basic CBC, like those types of things.
Right.
Yeah.
B12.
Yeah,
B12.
but you're the most important thing, like Nate is saying, is that the history. Like, are they depressed? How's their sleep been doing? Have they been drinking every night? Like, what's going on in their life? What's their functional status? And we'll have a link to those Alzheimer's diagnostic kind of guidelines, which I think are fabulous. Great flowcharts for anybody who wants it. And importantly, those biomarkers are really reserved mostly for specialty care.
Yeah, I think they nicely described that.
Eric just gave kudos to the Alzheimer's
I give
Association.
kudos.
How about this?
Yeah, it was great. Importantly, there are no pharma or diagnostic companies involved in that work group. So kudos on that too,
Good.
like starting to think about conflicts of interest.
Yeah.
So big kudos. I'm going to get off my rant.
To the next one.
Yeah, to the next one. I'd love to hear your thoughts. So let's say you do this diagnostic workup. You have diagnosed with MCI or mild dementia. You send them to the specialist. It's confirmed. They do blood tests. They may do a PET scan. What do you think the role of the amyloid antibodies are in this case? Like, how do you talk to your patients about the benefits and the potential risks? I'm not going to ask you for the 40-minute spiel. I'm going to ask you for the 30-second spiel.
Yeah. Well, this is where I think shared decision-making is so important. And I do, in our program, we do offer monoclonal therapy, lecanemab and donanemab. And I talk to all of my patients that fit eligibility criteria. And most of my patients are coming into a specialty clinic with that in mind. And so every single person, pretty much with that diagnosis of MCI or mild stage dementia, will hear me talk about monoclonal therapy. And usually for those that aren't eligible, I'll say, you're not eligible because you have moderate stage dementia. You're not eligible because you're on a blood thinner. You're not eligible for A, B, and C. So they'll hear that because I want them to know that. And then for those that are eligible, I'll say, okay, so you're potentially eligible. There's a separate evaluation process for determining if you really could be on this therapy. But let's talk about if you really want to go through with that and what that means to be on the therapy. So I actually start with logistics. Are you willing to go into an infusion center every other week? It may not be in your area. You might have to drive an hour or two to do that. Are you willing to get an MRI scan 4 or 5 times over the next 18 months? Do you have someone who can take you there? If you are on this medication and you have a stroke or a heart attack, you wouldn't be able to get certain medications because you could have this bleed. And then let's talk about the bleeding and the swelling that could go on in your brain. So I go over ARIA, and I think that's really important for people to hear. And so I pretty much present it as, I start by saying, these are the risks of this.
Yeah.
And then I'll say, what it can do is pretty incredible. It removes this protein, the starting protein, and they all know what I do. So all of my patients that see me know that I'm mostly in research. It's pretty incredible. It removes this protein. But what does that mean for you? It slows your decline. You are still declining. And I say it the same way. You are still declining, but it slows it. And they'll usually say, well, isn't that what your donepezil is doing for me? Well, and I'll have to say, no, donepezil doesn't actually slow it. It helps with your symptoms. You're still progressing. This is actually addressing your biology. It's slowing it. What does that mean? Potentially 3 to 6 months.
3 to 6 months of
prolonging where you currently are versus not being on the therapy. That's sort of the way they framed it. And I just say that's a statistician that sort of framed it that way. And then I'll go over like if this is your life goal, what are you hoping for?
Do you talk about uncertainty? Like what happens after a year and a half? Like that unknown that we have with these drugs.
We don't know the long-term consequences of this. I will say to you, people will say, oh, that's kind of interesting. And then I'll say to them, we don't know the long-term consequences of Ozempic. And everybody wants to be on that drug. We don't know the long-term consequences of lots of drugs. And yet nobody seems to question that. And so everyone seems to question the long-term consequences.
I'm going to push back. There's a little difference between this and a statin, though, right?
No, Ozempic, everybody wants to be on Ozempic.
Yeah.
And we do know about 20 years. That somebody recently pushed back and said, well, it's been around for 20 years.
It has been, yeah.
But, there's a lot of drugs that come out that people don't seem to mind. But for some reason with Alzheimer's,
maybe it's the brain bleeds.
Maybe it's the brain bleeds. Maybe it's the couple deaths. People have died in other clinical trials too. I mean, I do feel like everything is heightened in this field. That's true. I also worry that like part of this is the taint that aducanumab put over everything.
It was the worst way that we could start. And when we wrote this, I feel like I'm just doing everything in my presentation.
Oh, this is great.
We had this great editorial in JAMA. This is my first editorial in JAMA, thanks to Eric. And we were very fair about this. This was a horrible way to start these therapies, was with this approval.
That was our first paragraph, I think.
Yeah. And it just...
Well, I want to ask, because I'm going to bring you to your last article that I was just reading last night again, which I thought was fabulous. It was in New England Journal last year. Like you were in New England Journal 3 times, 2 videos last year. But you wrote an article about what primary care needs.
Yeah.
Like if you had this magic wand that you can change how primary care thinks about diagnosis, screens for Alzheimer's disease, what does primary care need? And we'll have a link to your New England Journal article, so listeners want to know more, they can read it.
Yeah.
What does primary care need around Alzheimer's disease?
Oh, gosh. I think based on talking to my colleagues, I think primary care needs more time with their patients without the pressure to go through they need more than 18 minutes. They need more people working with them. They need social workers like I have. They need more nurses. They need more of that support. And then I feel like they know so much about Alzheimer's and cognitive impairment, but I think they want more training in the ability to counsel people on these conditions, particularly geriatricians, I think really want to be experts in this field.
Yeah.
And so I think of it as the 3 T's: time, training, and team. And so I think the system needs to be supporting the clinics. And so it's a structural resource change.
And I just want to also acknowledge, because you said geriatricians and specialists in the field, I just want to acknowledge that individuals like you, Nate, Sharon Bragman, Heather Whitson, like we have so many amazing people as geriatricians who are leading the way as specialists, not just as geriatricians, but as dementia specialists. And, I think that is a sign that geriatrics has a really important role in the future of dementia care.
Oh, this brings me to my last question. That's a great shout out. And there's been all this stuff. There's an article in the New York Times about the decline and fall of geriatrics as a specialty last week. We had a podcast about this. We talked with Jerry Gerwitz. We had Mike Harper on. Is this a field where geriatrics can, make a claim, establish expertise and potentially lead to increased revenue through giving these antibodies in infusion centers?
Oh, well, that's a different angle that we've never really thought about. We are cost saving. We save healthcare. Geriatricians do by taking care of complex patients. But I'd never heard of it. Yeah.
Because these are infusion centers, right? You're infusing.
Yeah.
Well, in 5 years, are we still going to be infusing these,
centers.
or are we just going to give sub-Q shots to
Right,
everybody?
I agree with
So things are changing. Well, I'm going to skip over that last question because we're out of time, Alex. Wait,
Get you a little bit more time.
a little bit more
All
time.
right,
You're the one who has
do
to
your
go.
last. Yeah, I have to go around with patience. Last question. Go
No,
for
no,
it.
no, no. That was
That was the last question.
that was the last question.
Okay, we're done.
We're done.
All right.
We're
so-
done. Geriatricians,
It's a little bit of a jungle.
you
Land
have your
podcast
shout out.
today.
Dementia care, you are the experts. And with that, Alex, a little bit more, Bruce.
Well, maximum lawman run down flamingo, chasing a rat and a barefoot girl. The kids round here look just like shadows, always quiet, holding hands. From the churches to the jails, tonight all is silence in the world as we take our stand down in jungle land.
It's like the GeriPal theme song. It's like Jungle Land in here.
Yeah, thank you.
Nate, thanks for joining us on this podcast. And also a big shout out. If you guys haven't listened to Nate's podcast, Dementia Matters, go to it. One of my favorite podcasts out there. Thank you for doing that too, Nate.
Yeah, thank you guys. It's been great.
And thank you to all of our listeners for your continued support. We'd also like to thank everybody who's donated over $250 to the podcast over the last year, including
Daryl Owens, Craig China, Mike Steinman and Dorothy Richmond, Diane Meyer, Matt Schuster, Harry Hahn, Elizabeth Chung, Wendy Peltier, Kelly Strait, Jeffrey Galbraith, Ron Sabar, Rebecca Goldstein, Anna Lynch, Deborah and Jeffrey Larson, Krista Masak, Ed Martin, Stuart Oserman, Mo Rizawi, Rochelle Bernacki, Daryl Owens, Mark Wren, Richard Lewis, John Bielenson, James Tulsky, Elizabeth Cobbs, Christopher Heck, Meg Walhagen, Chris Jones. Thank you all.